Welcome to the Aging Well podcast, where we explore the essential elements of longevity, well-centered fitness, and proactive health choices. Today we are diving deep into the world of prescription medications with Dr. Jerry Avorn, a distinguished physician, researcher, and professor at Harvard Medical School. Dr. Avorn is widely recognized as a leading voice in evaluating drug safety, efficacy, and policy. His latest book, Rethinking Medications, Truth, Power, and the Drugs You Take, exposes the hidden forces that shape our pharmaceutical system, from the FDA's shifting approval standards to powerful lobbying of the pharmaceutical industry. He challenges us to rethink how drugs are developed, marketed, and priced, while offering actionable solutions to ensure medications are safe, effective, and accessible for all. In this episode, we'll explore critical issues such as why the U.S. pays the highest prices for prescriptions, how regulatory oversight has weakened, and what steps we can take to protect ourselves as consumers. Get ready for an eye-opening conversation about the medications we rely on and the system behind them. Dr. Avorn, welcome to the Aging Well podcast. Can you tell us a little bit about yourself and your path to medicine and rethinking drugs and how they're evaluated and prescribed?
Sure. I guess I wanted to be a doctor since I was about 7 years old and hardly ever wavered from that. There was a period in college where I thought maybe I would just become a clinical psychologist because that's what I thought I wanted to do in medicine. But then I decided that I would just go the medical school route, in part because I needed the draft deferment, because if I didn't go to medical school, I might have gotten sent to Vietnam. So I went to medical school at Harvard and got a bit of a look at psychiatry and said, I think I'd rather be an internist. And went through training in internal medicine in the various Harvard hospitals, and then decided that one of the most exciting and important parts of internal medicine was geriatrics. So I helped to get the geriatrics program at Harvard Medical School started back in the 80s, and we set up what we thought was going to be a really dynamic world-class program to train the next generation of geriatricians. And then, for reasons that are still not clear to me, both Harvard and the teaching hospital that I worked at decided in 1997 to end their geriatrics programs. And my friends and I would joke about, well, is that because they figured out that the population is getting much younger and we don't need geriatrics anymore? But for whatever reason, both Harvard Medical School and one of its main teaching hospitals said, we're not going to do geriatrics anymore. So I had a major interest in medications and the elderly. And so I ended up studying them not from the elderly clinical perspective, but from the medications perspective. And I was given my own division to run, in which I was able to do my research on medications in the elderly from the medications end and not from the elderly end, because for some reason people didn't want to have programs in aging anymore. So I continued that work. And to this day, I've been particularly interested in medication use in older people, and have now developed a research unit that has about 80 people in it and a lot of grants, at least until recently, from the federal government, the NIH, and the National Institute on Aging. And we study patterns of prescribing and adverse effects and beneficial effects and whether people can afford their medications, again, with primarily an interest in older patients. So that's my history in a nutshell.
And what inspired you to write Rethinking Medications?
Well, it seemed like there was an awful lot that we had found in our research, in my research group at Harvard, that was not widely known to people, that seemed to me to be awfully important, whether from the perspective of a prescriber, which I have been for many years, or from the perspective of my patients, or from the perspective of policymakers, or frankly, anyone who pays health insurance bills or pays taxes, because a lot of the financial issues end up being shared by everybody, whether people want to or not. And there was a lot that is not widely known about how FDA decides whether a drug works or not, how companies decide what they're going to charge for a drug, how side effects are detected. And I said, wow, this is really interesting stuff. Why don't more people know about it? So I decided to write Rethinking Medications to let more people find out about all this neat stuff that I've been studying for the last 45 years or so.
And can you share some of those key moments in your career that have shaped your views on the pharmaceutical industry and drug policy?
So not only, the industry looms large, the FDA looms large, the insurance companies and prescription benefit managers loom large. What has interested me is the way all those pieces kind of fit together. Who is doing what to whom in terms of the way the FDA is influenced by industry, the way both of them are influenced by Congress, the way Congress and the executive branch are influenced by industry lobbying dollars, the way doctors are influenced by ads, the way patients are influenced by ads. And so it's really this very fascinating mix. One example, for instance, was that I remember taking care of a wonderful older woman who had high blood pressure, and no matter what I prescribed, I couldn't get her blood pressure down. And, we all know that you want to control high blood pressure, especially in older patients. And so I kept adding meds to try to get on top of her blood pressure, and she just remained hypertensive. And then there was a long weekend that I was out of town with my family, and I come back and found that she's admitted to the intensive care unit. And the reason was that she had come into the emergency room with something unrelated. They looked at the long medication list that I had diligently put in her record. She needed to be admitted, so they put her on all the medications that I thought I had prescribed, and she dropped the bottom out of her blood pressure. And it turned out many days later, and after her getting quite sick and then recovering, that she had not been taking any of the medications because she didn't have good health coverage and she couldn't afford them. And she was too embarrassed to tell me as her doctor that she couldn't afford what I had prescribed. And so she just would, let me give her prescription after prescription. I never knew they weren't getting filled. And when she finally was given them in the hospital, that was, more than she could handle. And her blood pressure, went down to dangerously low levels. And so I guess the fact that so many of our patients, especially older patients, even though Medicare does cover drugs, still cannot afford, whether it's the copay or whether it is perhaps an older person who is maybe 63 and not yet on Medicare. The financial burden is just so enormous that we have all these wonderful medications that we've discovered over the years that our patients are not able to pay for. So that was one kind of key experience that really made me try to understand, why are drugs so expensive? Why do Americans pay twice as much for any given drug as people in Canada and Europe and Japan and Australia? And what can we do to fix that? And the story of that lady was told in greater detail in my last book, which was called Powerful Medicines. And that was published by Knopf quite a while ago. But it actually turns out that the section on medications and the elderly that I wrote in Powerful Medicines is every bit as true today in many respects as it was back when I first wrote it many years ago.
And I was blown away reading your current book that this is the price of some of these medications, and many of which are not even demonstrated to work. I read the chapter on the muscular dystrophy drug, and it was like 30 some odd thousand, and this was back in the 80s, a year for a medication that maybe worked a little bit, but not much to make it really worth taking. Right. Same with Alzheimer's drugs.
Right. And Jeff, it's particularly galling when some of these medications were developed mostly with taxpayer dollars. And that strikes me as really kind of a double whammy, that if a researcher gets a grant, let's say from the NIH or from some other source that is a charitable or governmental entity, and they use that to develop a drug, and then they say, great, I now own the drug in my company, and now I'm going to charge whatever I want for it. That is even more annoying than just the run-of-the-mill drugs are expensive problems.
Yeah. And so how has your research at Harvard Medical School influenced your understanding of prescription drug safety and regulation?
Well, the real 500-pound gorilla around drug safety for me was an anti-inflammatory drug that many of your listeners and viewers will have taken back in the day, called Vioxx. And for a while, it was the best-selling drug on the planet. And it was made by Merck, and it was a non-steroidal, kind of like Advil or Motrin, but it had the added property of reducing the risk of stomach and intestinal bleeding, which was a good thing. But there was a concern that it might, in exchange for that, increase the risk of heart attack and stroke. And the company said, no, that can't be. And the drug was selling at a level of billions and billions of dollars a year. And our research group at Harvard and at the Brigham and Women's Hospital, which is the teaching hospital that I work at, said maybe there's more to be discovered here because the company says, no, it can't cause heart attacks. There was evidence, especially from some of the clinical trials, that there were more heart attacks than one would expect in the people who were randomly given Vioxx. So to make a long story short on the full details, which are actually pretty interesting, are in Rethinking Medications. But essentially, I decided to do a study with my colleague Dan Solomon and look at the patterns of use of Vioxx and drugs like it in tens of thousands of people for whom we had all their medication use and all their clinical events. And we stripped everyone's name and identifiers off because I didn't really care who they were, but I wanted to trace their use of drugs over time and try to understand, did people who took Vioxx have more heart attacks and strokes than people who took similar meds? And as it turns out, they did. And we made that finding, and Merck said, oh no, these people don't know how to do research. That can't possibly be. They told us, don't publish it. You'll become a laughingstock in the medical community. But Solomon and I and Sebastian Schneeweiss and others in our group were convinced we got it right and that the world needed to know that that was the case. So we published our findings, and it turns out that we were right and Merck was wrong. And within a year, they had to take the drug off the market because it tripled the risk of heart attack and stroke. And so that for me was a very telling example of how we could do such a better job in tracing drug side effects than just saying it's FDA approved and let people figure it out from there. And FDA actually, after the Vioxx debacle, as I describe in the book, they did initiate a very ambitious program that is now in place that enables them to track side effects of drugs once they're on the market, which amazingly, they were not doing very well before that. And now they are. So I think we're in a better place because of that. But that you could have the best-selling drug in the world triple your risk of heart attack and stroke, particularly in older patients, and have no one know for 5 years, and it was on the market, taken by 20 million Americans. We spent, as a nation, billions and billions of dollars on the drug, and it was so dangerous that it's not available anymore. So that was a wake-up call for me that, gee, we could be doing so much more to understand drug side effects than we were at that point doing.
So you argue in the book that the U.S. prescription drug system is at a crossroads. What are the biggest threats to the integrity of the system today?
That's a very good question. I think the biggest is, and God only knows now that we're in a new administration that has its own ideas about many things in healthcare that don't always match what most people who look at the science end of it believe about healthcare and medicines. But we are at a point where we need to really think hard about how does FDA give the green light to a product. As I was writing the book, which has taken about 4 or 5 years, it looked like maybe we might be inching toward more carefulness and not having FDA approve a drug just because it makes a particular lab test look better, which unfortunately is the way a lot of drugs are being approved these days, even if the manufacturer doesn't show that the drug actually helps people. And we're still understudying drugs in older patients. And it's ironic that even though older people by far take more drugs than younger people, they are studied less and less in clinical trials, unless, you got to study older people because it's about Alzheimer's. But if it's about diabetes or high blood pressure or heart disease, companies would much rather not have people much over 65 because they think it's too complicated. And yet, those are the patients that I would be prescribing the drugs for most. So I had hoped until November 5th, just to pick a random date of last year, that FDA could be coerced or cajoled or educated into having higher standards for approving drugs and not just say it makes this so-called surrogate measure like a lab test look better, but it actually, if it's a drug for cancer, it actually helps people to live longer, better lives, not that it makes some marker look better or an imaging study look better and then leave it at that, which FDA and the industry have been more than comfortable doing. And I thought we were kind of sounding the alarm bell on these issues pretty loudly. Now, as we look at what's going to happen with the new administration and its general approach of not wanting to regulate things too much, I worry that we may not make the progress that I had hoped that we might make, and we might even backslide a bit and continue to be a little too loosey-goosey about, okay, it improves a lab test, fine, you can have your drug on the market, and you have 10 years to show whether it helps people. which is what the FDA said about the notorious drug for Alzheimer's that it approved, even though it didn't work, and then had to take off the market. So yeah, so we're at a crossroads, sure enough, but I just don't know if we're going to have things get better or get less good as a result of the politics involved now.
Yeah, and I think that's the sad part of this all is that politics have gotten so involved in the whole process, and and finances have gotten into it as well with, like the pharmaceutical companies. And what role do the pharmaceutical companies play in shaping drug policies and influencing some of these medical guidelines?
That is really a key issue, Jeff, because a lot of us believe that this ought to be only about the science. And people can be liberal, conservative, progressive, whatever. But at the end of the day, our health policy and our decisions about medications, especially for more vulnerable people like those over 65, who really depend on medications to not just live well, but to live, and who also don't have a ton of disposable income to throw around, that for everybody, but particularly older patients, we really ought to let science call the shots. And unfortunately, we have gotten into a situation where science is sometimes not the only determinant of whether a drug gets approved. Often it is lobbying, often by the manufacturer. Often it is the involvement of these prescription benefit management companies that are in the middle and take their cut of whatever profits there are. Often it's the politics of, well, we need a drug for this, let's approve it even if it doesn't work. And I would like to see us return to, or get to, I'm not sure we ever were there, a situation where at the end of the day, and again, vaccines come up as a timely example, whether vaccines ought to be used or not, and whether they are safe and whether they work, ought to be only about the science. And if the science says this is a crappy vaccine, it doesn't have a lot of effectiveness, it causes bad side effects, great, that's how we should make our decision. But if the science says this is a very effective vaccine and it prevents a lot of illness with hardly any side effects, then that ought to be what drives the decision both of patients and the government and payers. But I worry that politics has now begun to infiltrate so many of our decisions as a country about whether a given product is a good one or a bad one, that it becomes really distorted and we're no longer looking at facts, we're looking at ideology. It doesn't really have or we're looking at lobbying in the case of a lot of medications. And, neither ideology nor lobbying really ought to have a place in decisions about approving or using a medication.
Yeah, we've kind of thrown around this idea, we follow the science over the last few years. That became a popular phrase in COVID. And it's like, you're really following the science, and that goes for both sides. I think, if it's science, then you're talking randomized controlled studies and you're talking data and data only, and you're talking probabilities and not possibilities.
Right.
And, I think we need to wake up to that quite a bit. And I think another big question is about why we are paying such high prices. You talk in the book how the U.S. pays the highest prices for prescription drugs. Right. What are some of the forces that are driving these high costs?
It's an interesting problem because we are the only country on earth that allows the manufacturer of the drug to have the sole say in what that drug's going to cost. And we do a lot of work with colleagues in Europe and Canada and Australia and many other countries, and they have scientists who look at a drug when it's approved, and they will evaluate what does it do for patients, and they will come to conclusions either this is a wonderful new product, it's helping a ton, and we ought to really pay a lot for it, versus this is no better than what we've already got on the market, so why would we want to pay more than for maybe even some generic drug that costs a tenth the price? We do not have that here, and for older patients, we have this added layer of the Medicare program, which it's wonderful that Medicare covers the cost of drugs because that's like one of the most important things we do for patients. On the other hand, when that was put in place, the legislation was written that Medicare cannot ever ask any questions about what a drug costs. And for most of the most important drugs, it's got to cover everything that's out there on the market. And this was presented as a way to protect older people, from the government making bad decisions. But really what happened was that it became open season for companies to charge whatever they want, know that Medicare was going to have to pay for it. The same, by the way, is true of Medicaid in many instances. And we wrote this legislation back in 2003 that created the Medicare drug benefit. The congressman that wrote it from Louisiana immediately thereafter quit Congress to become the head of the lobbying group for the pharmaceutical industry and, kind of revealed where his heart was all along. But we're left now with this really kind of nonsensical approach that no other country has, that the price is whatever the manufacturer wants it to be. And that, unfortunately, besides really making our healthcare costs way more than nearly every other advanced industrialized country, and by the way, we don't have better outcomes for that extra price. We have outcomes that are actually sometimes in the middle of the pack or toward the bottom compared to countries like France and England and Australia and Japan and, most of mainland Europe and so forth. So we're not getting more for our bigger expenditure, but we are really socking it to patients. And even with the Medicare drug benefit, older patients are at particular risk of getting hit with very unbearable drug bills that sometimes can push them over the edge financially. Now, back in the Biden administration, some legislation was put into place to protect older patients against that problem of high drug costs. But I understand that the new administration wants to undo a lot of those protections, and we'll have to just see where that goes.
Yeah, I was shocked in reading the book. I think it was one of the muscular dystrophy drugs that was formulated by a company that claimed to be so poor that they couldn't do a really large randomized control study. They had a study with 12 patients.
Right.
And then they turn around and they were charging $32,000 a year for the drug.
Yep. More like $300,000 a year for the drug. Yes. And,
that's right. Yeah.
Yes. And the then deputy head of the FDA said, well, she was concerned about the economic well-being of the company. And last time I looked, FDA's job was to make sure that drugs are safe and effective, and they're not out there to line the coffers of drug companies. And that company actually went on to say, wow, that's a pretty easy way to make a buck. And they introduced several similar drugs, none of which worked. But according to that principle that FDA is there to help drug companies make money, each one of them came onto the market for around $300,000 a year. Each one of them doesn't really work hardly at all. And, we all get to pay for that as taxpayers, as people who have health insurance, as people who it's not a big drug for older patients, so it doesn't loom large in Medicare. But many of the other drugs that I write about in Rethinking Medications do get covered by Medicare. So whenever a horribly expensive drug that doesn't work gets paid for by Medicare, it's actually everybody in Medicare that ends up getting hit with the responsibility of paying for that in their premiums.
And many people assume that FDA-approved drugs are thoroughly vetted. What should consumers know about the approval process that might surprise them, other than some of the things you've already alluded to?
Right. Well, a lot of people, and when I say a lot of people, I include a lot of doctors, maybe even most doctors, and probably most patients, believe that FDA tests drugs and decides if they work or not. FDA does not test drugs. It is almost always the manufacturer that is seeking to market the drug that does the testing of the drug. Now, FDA looks at the results pretty carefully, but the way the trial is set up and the company's initial spin on it before FDA looks at all the data is clearly going to be oriented around the company's needs. And, you can't fault them for that. They've got shareholders. They want, people don't invest in a drug company to, in their retirement account to do good works. They do it because they want to have a nest egg they can retire on. And the company says, fine, we're here for our shareholders. The way we enrich them is by charging a lot for our drugs. And with no pushback on the part of government, they do charge what they want. And if the testing of the drug ends up being a little skewed, as in the description of the drugs for either Alzheimer's or for some of the other examples in Rethinking Medications, if the company says we're paying for the study, we'll do it the way we think we need to, that's really an open door for the results to maybe not be everything that the actual patient or doctor using that drug wants to know.
Another thing sad in the book was, when you see that You have patients that are so desperate for help that they end up pleading for certain medications to be approved just because it has a little bit of an effect and it gives them that slightest amount of hope, and they're not realizing how they're going to get screwed in the end.
Exactly right, Jeff. Especially if the drug works pretty much not at all. And I write about what happened with muscular dystrophy drugs that you mentioned, where, lots of kids in wheelchairs were paraded into the FDA hearing room. The parents and the kids would say, please don't let little Johnny die. We need this drug. And, I can understand that. If I had a child with muscular dystrophy, I would, certainly want everything to be done. But it's not doing, little Johnny a favor to have him on a medication that actually is ineffective. But these are kind of displays of sort of public pressure, and sometimes the patients are flown in by the company that makes the drug, and it's hard for the advisory committee to say, I'm not convinced this drug helps, and so we're not going to approve it. And when I describe some of those hearings, you can see how torn the outside advisors are. They want to do the right thing. They want to help the patients and the families, but it's not clear that it's doing anyone a lot of help to approve a drug that's ineffective.
So how can patients and healthcare providers better evaluate the safety and effectiveness of the medications they are prescribed?
Well, when I sent in the manuscript of Rethinking Medications to Simon & Schuster, my editor there said, put in a section that is for patients and tell them exactly the question that you just asked, Jeff. Tell them what they can do for themselves. And so there's an entire appendix in the book that is what you ought to know about the drugs you're taking and how to ask the right questions, where to look up more information, how to think about whether there are alternatives that might be better for you or safer or more affordable. And that kit, which was not originally part of the book, but I'm glad he made me do it, is something that for readers who may be interested in some of the tales of how drugs get approved and how we learn about side effects and politics of why they are so expensive. But there's that appendix that also says, here's what you, Mr. and Mrs. Public, can do when you're prescribed something to understand more about what your doctor is giving you and how you can work with your doctor or your nurse practitioner to understand what you're getting and to have a conversation with them about the choices that you're being asked to make, and have that be a discussion and not just, here's something, I phoned it into the pharmacy, take it, but really make the patient into kind of a full partner in those discussions.
I was going to ask, who should they have that discussion with? We've had a few physicians on the podcast who have suggested it's a wise idea to have the conversation with your pharmacist about the drugs that you are taking, because they sometimes know a little bit better than the physician what all these interactions could be and some of the efficacies of drugs and things like that. Would that be the case in your mind?
I think pharmacists are one of the most talented and underused resources in the healthcare system. They know, as you say, they know a ton about medications. That's the good news. The bad news is, especially in the chain pharmacies, they are put on such a short leash by the companies that run the pharmacies that they are expected to just churn things through at a rapid pace. And the companies, and because we've actually talked about this with senior people in some of the bigger chain pharmacy companies, they said, look, our business is filling prescriptions and putting them through as quick as we can. We don't really have room in our budget for the pharmacist in the local drugstore setting to take the patient aside and talk with them about this med and the other meds they're on and what to watch out for. You still do get that in some of the smaller mom and pop pharmacies that can still afford to do that, which is, I talk to pharmacists, they say that's why they wanted to go into pharmacy. But in a lot of the chain stores, and many of your listeners and viewers will have experienced this themselves, things are run at such a rapid clip that, you may get to talk to a pharmacy technician, but they're not a full pharmacist. And the emphasis really is on throughput. So if you can find a pharmacy, and again, it may be a small independent pharmacy, where you can actually get the pharmacist to talk to you, that is great. Some practices actually employ pharmacists in the practice, and we see this more in these big integrated healthcare systems like Kaiser Permanente or the Veterans Affairs system, where the pharmacist is seen as a member of the healthcare team. And if you have a practice that you're in like that, that's wonderful too. But good luck if you're trying to fill a prescription and manage or to get a pharmacist on the telephone in some of these large chain stores. You simply can't do it. So I think at some point it's okay to sit your doctor down or your nurse practitioner, and in effect say, look, you just told me to take this complicated chemical that's going to cost a lot. I want you to explain to me, what's it for? Why are we using this one? What side effects should I watch out for? And although doctors and nurses are also subjected to that same kind of conveyor belt approach that seems to dominate medicine so much now, nonetheless, if you can kind of grab them by the lapels and say, look, I need you to spend 5 minutes talking with me about my medicines, that is going to be worth it, even if the doctor or the nurse says, I got 25 people in the waiting room, I'm really kind of pressed today. I used to, when I was doing a more primary care, I would have my patients bring in, we used to call them brown bag sessions. And I used to say, bring me everything you're taking in a brown bag. I want to go over what you're prescribing. The first time they might bring in what I prescribe for them. But when I said, are you seeing other doctors for other problems? And they said, yes. You want me to bring in those medicines too? I said, yes, they're all going into your body. And then they'd come back and they'd bring me the other doctor's medications, some of which might be duplicative of what I prescribed or interact with it. And I say, are you taking any supplements or over-the-counter medicines? Oh, you want me to bring those in also? Yes, I do. That's going into your body, and those are chemicals that can have an effect. So finally, when I would get the patient to, and I learned eventually to tell them the first time around, every doctor you're seeing, every over-the-counter, every supplement, just bring it in the same bag. I would learn amazing things that, you're still taking that. I thought we stopped that, a year and a half ago. Oh, well, the drugstore keeps refilling it. Or, oh, you're getting that supplement. What do you think it's supposed to do? Don't you know it interacts with your blood thinner? No, nobody told me that. So those may have been some of the more useful moments that I ever spent with any of my patients. And by the way, if your doctor doesn't ask for that, I think the patient can initiate that. Just come in with your own brown bag and say, Doc, I'm really kind of perplexed. I'm taking these things from various sources. Can we just spend 5 minutes going over all of my little amber bottles and tell me what I should keep taking and tell me which ones I shouldn't be on and tell me if there's any supplements I'm on that are either useless or dangerous?
I think that's an important characteristic to look for in a, general physician, that they're going to be asking you those questions. I remember, my grandmother commenting to my grandfather's doctor when he prescribed something. She's like, well, should he be taking that because he's also taking this? And he's, oh, you're right. That's, and they changed the prescription. It's like, you're the stinking doctor. My grandmother had a high school education and she was able to pick up on the fact that you were prescribing something that was going to have an adverse interaction with something else you prescribed for him. It wasn't like he was even taking it from another doctor.
Yeah, thank goodness she raised that because, a lot of people either don't know to raise it or are too timid to raise it. But hey, it's your body. You only have one of them, and you got to be proactive in making sure that what you're getting is the best thing for you.
And in the doctor's defense, too, I mean, they have hundreds of other patients that they're dealing with as well. And, I don't know how they could possibly keep track of all the medications some of our older population are taking. I mean, you see some...
Jeff, especially if they're getting it from another doctor. So I may know exactly what I prescribe somebody, but if they're going down the street, for their arthritis or their heart disease to somebody else who may not be in my system, I will never know about that. And the pharmacist sometimes catches those things, and pharmacists are often the unsung heroes of the healthcare system. But unfortunately, people are sometimes obliged to go pharmacy shopping because the place down the street has got a better deal on my heart medicine. So I'm going to fill that there, and I'm going to fill my blood pressure medicine here. And that makes it impossible even for the pharmacist to know everything you're taking.
So what role do you think like AI and the internet play in this whole question?
Good and bad. Let me take the easier part first, which is the internet. Actually, just last week, I was with my wife at her doctor's, and I mentioned something about a side effect of one of the meds that she was taking. And he said, oh, who told you about that? Dr. Google? And I said, actually, no, I read the original paper in the medical literature about it. But yes, the internet is a mixed blessing in that it is a way of finding out about a lot of things that you used to have to go to a medical library to learn. That said, some of that information is very valuable and some of it is garbage. And it's not always easy to know which is which. In the book, in that appendix I mentioned about advice for patients, I say stick to reputable sources like, for example, the Cleveland Clinic or the Mayo Clinic or Johns Hopkins all have very big internet presences if you just go to look up a condition or a medication. If it's on the Mayo site or the Cleveland Clinic or the Hopkins site, you can know that it is very likely to be correct. If it's on the site of some fringy supplements peddler, I would not even spend time reading it. So that is how to use the internet for what it's best at. Unfortunately, FDA is kind of useless in this regard, because if you go to the FDA.gov website and you look up a drug you want to know about, it has got the most user-unfriendly, irrelevant listing of garbage of every meeting FDA ever held about that drug and all the actions they took, but you can't get through it. I have trouble getting through it as a doctor who studies these things. But I think if you go to the internet and you stick with sites like Mayo or Hopkins or Cleveland Clinic, you'll get good information. Artificial intelligence is, I think, at least at this moment, so far a mixed bag, because one of the kind of shocking anecdotes that I talk about in Rethinking Medications is that there was something that actually, when Google was last year rolling out its new AI function, where instead of giving you links, which I like because then you can go back to the original paper and see where was it published and was it peer reviewed, Google decided that they're going to give people an AI summary, which is, instead of the links, it'll give you a couple of paragraphs summarizing everything. And the one that struck my eye, which got a lot of notoriety, was somebody had put in a question about keeping your calcium levels normal. And Google's fancy new AI overview said, geologists at Stanford recommend eating a small rock every day to elevate your calcium levels. And there it was for all the world to see, with, courtesy of Google. It turned out that when Google's AI system was scraping the internet and looking at everything that they could find about a given question, they found an article that was in The Onion, the satirical magazine, that just made up something funny about you can keep your calcium levels up if you eat a rock every day. The AI program didn't know that it was The Onion and not the New England Journal of Medicine. So they put that in, and that ended up at the top of the list of Google's recommendations about your calcium levels. So I cite that as an example of how it will get better, and no doubt there will come a time when AI is better at being able to tell The Onion from the New England Journal of Medicine. We're not there yet, and we need for that to be a little bit more mature before we can really take that stuff as a guidepost, especially for something where your health is involved.
The sad thing is there's a lot of humans out here that they can't distinguish between, something in The Onion, what's satirical versus what is real. And I think we really lack some of the scientific literacy that we need to be able to say, okay, I've seen this article and they're talking about, like one that I've brought up before as an exercise scientist is an article that talked about a glass of wine is equivalent to an hour at the gym. And it's like, okay, let's kind of tease through that. Yeah, there might be some physiological changes that are affected by drinking a glass of wine, but there's more calories. You're putting calories in rather than burning, and you're not building muscle. You're not working your heart. Let's be a little bit more real here, people. And I think a lot of people, they read these headlines and they're like, oh, great, this is what I need to do. And they don't look at the source.
Exactly correct. Right.
So what are some common misconceptions about miracle drugs that get marketed as?
Well, the companies are in an interesting situation because I guess the SEC, assuming we still have an SEC later this year, requires that when a company finds out something that can materially affect their share price, they've got to immediately reveal it to the public. And I can kind of feel for the companies sometimes in that if they do a clinical trial and there are some promising findings, they feel they're legally obliged to blurt them out in a press release to fulfill the SEC requirements. The trouble is those often are, not only not peer-reviewed, but it may be just a big glimpse at one aspect of the study and very incomplete. And, most of us wait for the actual paper to appear after peer review in a real journal. And it's important, I think, for consumers when they hear, oh, there's a great new treatment, for lung cancer or Alzheimer's disease or diabetes, to ask themselves, where is this coming from? And is it something that is a peer-reviewed study, or is it a press release from the manufacturer, or is this just hype from some, supplements maker? And, there's a lot in the book where I ventilate about how supplements are not under the auspices of FDA or really anyone. And they get to make these crazy claims. And the ones that are about, this will restore your memory and this will enable you to lose 80 pounds. You could never say that for a prescription drug if it wasn't true. But if you call yourself a dietary supplement and there's little tiny print on the bottom of the visual part of that will say, this statement has not been evaluated by the FDA, and this product is not designed to diagnose or treat any medical condition, which of course negates everything that they say, but that's the little fig leaf that they get to put out there. I don't think people should take any of those claims seriously and, go to, one of the respected sources that I mentioned or another one that is not commercial or selling you a product and see what they say there. But, there are too many healthcare claims out there. It's almost like 100 years ago before the FDA had any standards for a lot of these claims that get made outside of the rubric official statements that are vetted and peer-reviewed.
Yeah, my 15 minutes of fame was I was quoted as saying, I will not be intimidated in the New York Times based on some research that I had done for a weight loss supplement back in the late 80s, I guess, early 2000s. And it turned out I was deposed twice for this product, and one case finally went to court, and they found that of the 7 studies done, ours was the only one that did not flat out fabricate data or design the study to be designed specifically to get the results that they wanted. And they were threatening me with a lawsuit if I didn't pull two abstracts that were submitted to a conference. They wanted me to report that there was like a 750 some odd greater % fat loss in the supplement versus the placebo. And I'm like, well, that's technically true, but first of all, we don't report data that way in science. And second of all, 750% of nothing is still nothing. And I bring that up to my students constantly because you see those kind of numbers, and I'm trying to remember what I saw it in recently, and I think it was even a kind of a drug treatment that they were talking about that kind of effect. And it's like, well, let's look at this data here. I wish I could remember exactly what it was, but it was dealing with number of people. And I was like, even if you went with like 1 in 1,000 people had this condition, 800 times better than that is not still that significant of a number. And we're probably dealing with numbers in the millions, 1 in a million, you're talking nothing. Yeah. And I think goes back to that literacy piece. We have to be able to understand that stuff. And it's probably something that needs to be taught better in school.
Oh, you said it. I think at every level, not just health professional or science programs, but also I think regular people ought to be helped to be better consumers of information because, as you say, those are the kinds of things that, you and your colleagues and me and my colleagues obsess about, but it can't be reduced to a big headline in a 30-second TV commercial.
So in the book, you discuss case studies from cancer drugs to opioids. Can you share a specific example that illustrates the dangers of the weak oversight?
Sure. Let me briefly pick one of each. On the opioid front, I tell the story of a TV crew that came to interview me, and they said, we want your reactions to this interview we just did. And they put on the screen a guy talking about how he was really out to make a ton of money selling this new version of opioids that were particularly addictive, and he was not above bribing doctors. And he told his sales force to wait outside of these pill mills because those are doctors that you can get to prescribe a lot of stuff. And my first reaction was, this is a joke, right? I mean, nobody actually talks like this. This is, if you want to make fun of the drug industry and opioids, why don't you just stick to reality? And they said, no, this is actually a guy who was just convicted and is going to do a lot of prison time because he was pushing a particularly addictive kind of opioid for a company that was the best-selling IPO, initial public offering company in its year. So this was not just some weird off-the-wall thing. This is a tremendously successful company. And this came to light, and as I describe in the book, it was on Frontline, the PBS TV series. I think you can still find it easily on the internet. And so that was one of the more striking things where FDA was so asleep at the switch and nobody was really paying attention to the utilization of these drugs. FDA approved it for very rare kinds of intractable pain in terminal cancer patients, And then they kind of lost interest and didn't realize it was being pushed to people who had a sprained ankle. That, for me, was an illustration of how off the rails things had gotten around opioids. And there was literally nobody paying attention at any level of government. And that, companies without much oversight will do what they got to do to make money. And this company sure did. So that was the striking example. And the other category you mentioned, Jeff, was, besides opioids?
Cancer.
Cancer, yeah. In the course of not just writing the book, but doing the research in my group with my wonderful colleague, Aaron Kesselheim, who's a lawyer as well as an internist, I have learned so much, and I tried to summarize it in Rethinking Medications, that, I think most of it, I as a doctor who thinks about these things all the time, and I'm sure most of my colleagues and all of my patients figure that if you have a drug for cancer, somebody has shown that it's useful for treating cancer. Duh. But as it turns out, FDA over the years has become so willing to just use what they call surrogate markers, that if it makes either a lab test look a little better or an imaging study look a little better, the company is not really obliged in practice to follow up and say, does this help the people with cancer? Does it make them live longer? Does it enable them to have a better quality of life? The FDA, and in fact, there was a report just last month by the Inspector General of Health and Human Services that said that FDA had pretty much gone off the rails in allowing this so-called accelerated approval program to become so undisciplined that companies were not bothering to do the follow-up studies that the law requires them to do. That, okay, let's get drugs out there if they're promising, and if it makes a lab test look better, great. And then the law then goes on to say, and the FDA has to force the company to then do the follow-ups to show that it's not just the lab test that gets better, it's the patient that gets better. And there has been this real deterioration in cancer drugs, but also other drugs as well, in which FDA just kind of loses interest and doesn't pay attention when the company does not do the follow-up studies. And the company gets to keep selling the drug at full price. Doctors don't always know that this was approved based on a little lab test change. They don't know that no one's ever shown that this cancer drug actually enables people with cancer to live longer. And that's, again, this is an interesting time because it's one of those periods in history where I think we need more careful regulation, not let's unleash the private sector and let them do their thing and get government out of their way. I want government to be in their face, at least when it comes to substantiating the claims that they're making about their product. So cancer was the other example where I was surprised, and that's why I thought it was important to put it in the book, at how many of the cancer drugs that we commonly use were approved based on this accelerated approval pathway. And then everyone kind of lost interest in the follow-up.
And psychedelics is another area that's gaining attention. We interviewed Neil Markey of Beckley Retreats in, I think it was episode 230. Mm-hmm. How do you view its potential benefits and risks from a regulatory perspective?
Oh boy, I think that psychedelics represent a really interesting and promising way of managing a whole variety of conditions, from PTSD to terminal cancer to severe depression. And the problem is that the government made it illegal for about 45 years to even do research in very carefully controlled circumstances on these drugs. They got swept up in the war on drugs, and Timothy Leary at Harvard didn't do us any favors by seeming a little out of control and giving people LSD whether they wanted it or not. I think that gave the field a bad name, and the war on drugs just kind of demonized these products as if they were as bad as heroin, which, they are not. And so for 40 years, very conscientious, smart scientists were not allowed to do studies, and we're only now beginning to see some good research come out. And there's a whole section in Rethinking Medications about some work that I became aware of around use of MDMA or ecstasy to treat PTSD. I'd gotten into the field actually when I was a medical student in the 70s, fresh out of my hippie days as an undergrad. And I heard that there were people giving LSD to terminal cancer patients to help them die. And that seemed fascinating. And I spent a month down in Maryland where that work was being done. And there are some remarkable case studies of people describing what they went through in the book in a very inspiring way. And then not long after I had that month tutorial over in Maryland. That research was shut down by the federal government, as was all other research in psychedelics until really just the last few years. So I think it's going to turn out to be, when we look back, a real missed opportunity, because we've had these compounds around for, decades, or in the case of drugs like psilocybin, for thousands of years, and they have great promise. They also have potential risks. And the way we study medications that have promise and risk is you do careful double-blind randomized trials. And it is only now that those are beginning to get off the ground. And the MDMA, or ecstasy study of PTSD, in which I knew a number of the principals that were conducting that research, came to a really bad end just last summer, because there were some real issues with the conduct of the trials, and FDA got very nervous about it and ended up saying, no, we're not going to approve this research, even though there were some life-changing anecdotes that seemed very tantalizing. But we're going to need to go back to the drawing board for all these drugs, LSD, psilocybin, MDMA, ayahuasca, all of them, and do the kind of studies that we subject other drugs to learn about them. There's one really interesting footnote, which is, if you're doing a study of cholesterol levels or blood pressure, you can do a double-blind study where the patient and the doctor don't know who's getting the placebo. You can't really do that with psychedelics, as I explained in the book, for obvious reasons. And so we're going to need to figure out a new way of how do you study these very promising drugs if you can't do a double-blind study, because somebody who gets one of these is going to know damn sure they were not in the placebo group. And so we got to get a new way of doing clinical trials, but it's doable. We just have been too afraid, and a lot of very conscientious doctors are still afraid of the federal government because these drugs remain illegal. And so it is shut down a very promising field, and I think we're going to look back in 30 years and say, wow, how did we let so many decades go by without even doing this research? Because there is going to be some enormous benefit. We just need to understand what it is and for whom and how to use these drugs well.
And we lost, maybe 2 generations of researchers on that?
Right. Yeah, there was such promise in the 70s with, people who said, this is the biggest breakthrough in psychiatry in 100 years. And look at these folks who are doing so much better. And then when I checked back with them a couple of months later, they said, nope, the studies were all shut down. And that desert lasted for 4 decades.
And think about how many lives could have been affected post-Vietnam.
You said it.
That we're finally starting to see, post-Gulf War and, the Iraqi wars and things like that, the PSTD that people are coming back with are hugely benefiting from taking some of these treatments abroad.
Exactly. And we can't use them domestically except underground because, the government says they're still illegal. And, we just need to get across that barrier, but it's been very slow in coming.
And they're legal in Oregon, where I'm at, but I think that legality is a bit, unstable. At any given election year, we could, lose that as well.
You said it.
And I think there's only...
We had a referendum here in Massachusetts last November for legalizing some uses of psychedelics, and it got shot down. And I know Colorado's been experimenting. And so there are little enclaves around the country, but it's in a very tenuous state.
So what practical steps can policymakers take to improve drug affordability and access?
Well, it's really an important question because there's a lot of people who basically, especially those who are retired or on fixed incomes, that are spending a ton of their disposable income to just pay for their medicines. So there's things that patients can do and doctors can do and the government can do. I can mention the government piece quickly because the government in the Biden administration actually did do some very important things, like having negotiations of price by the government in Medicare. And it looks like that may or may not survive the current administration. They set up a cap on out-of-pocket spending for drugs in Medicare, which was a real boon to a lot of older patients. I don't know if that's going to get undone as well. But I think whatever happens out of Washington, I think patients can definitely, when they are prescribed a medication by their doctor, they can always say, do you know how much this is going to cost? The doctor will inevitably say, no, I don't know. And that's not the doctor's fault, because it depends on what your insurance is. Is there a rebate? Where did your insurance and your prescription benefit management company place this drug on their tier of copays? And any given doctor will have maybe 50 different insurance plans covering his or her patients, including the ones that do the Medicare drug benefit. And so no doctor can literally sit there and say, you, Mrs. Jones, this is going to cost you $83 out of pocket a month. So it is often only when they get to the pharmacy that the pharmacist says, okay, your copay on this is going to be X dollars. And at that point, many patients say, I can't afford that. So I think the thing to do for the patient is to start the conversation in the doctor's office. It's not the doctor's fault if she or he can't tell you what it's going to cost, because they can't know the current deal with your insurance company and the PBM and the manufacturer. Well, what you can say is there a generic of this available? Because you know the generic is going to be way cheaper. And you can say to your doctor, if it's one of these more expensive new biologic drugs, which are the ones that are advertised endlessly on the evening news and around the clock on TV. And of course, the reason they're advertised so much is that they are incredibly expensive and the drug companies are making a bundle off of them. But some of them are also available in a cheaper form. For a biologic, we call that a biosimilar and not a generic, but it's the same idea. The patents have expired and other companies can make it. And very often it is pretty much the same drug. And so ask your doctor, is there a generic or a biosimilar of this available, which I know will be cheaper for me? And on the doctor side, I think we as prescribers have a responsibility for making sure that not only the drugs we prescribe are effective and safe, but also that they're affordable. And I try to help my colleagues think about, if you're prescribing X, do you know that there is something else you can prescribe that works every bit as good, but is now made by 12 manufacturers and not just one, and will cost a tenth the price? And those are conversations that doctors need to have with patients. Patients need to start with their doctor. And then, again, unfortunately, sometimes the harm's already been done by the time you get to the drugstore. But when the pharmacist says, that's going to be a $130 copay after your insurance kicks in, you still got to pay that out of pocket, to say to the pharmacist, what alternatives are there? And if you're lucky and you get a pharmacist that is not being swamped with needing to talk to 20 other people because there's only one pharmacist in the drugstore, they may be able to make a recommendation. But then someone's got to go back to the doctor, either the pharmacist or the patient, and say, oh, I understand there's a biosimilar for my very expensive Humira prescription. Could I be prescribed that? And then the clock starts all over again, and the doctor writes a new prescription. It's a crazy way to do it, but it's unfortunately something that I think all of us, doctors and patients and pharmacists, need to get engaged in. Otherwise, we just have everybody getting the most expensive drug, whether it's better or not. And then, unluckily, if it's like my patient who ended up in the ICU with no blood pressure, the problem is often that the patients just can't afford to take it, and then their condition goes untreated altogether. And I relate in the book the story of me trying to fill a routine prescription at the drugstore and having this, lovely elderly woman in front of me online. And she said to the pharmacist, how come my drug is going to cost $120? I have health insurance. And the pharmacist says, well, that's your copay. The health insurance paid the other $800 for the drug. And she said, well, you don't fill it because I can't afford that. And she walked away. And in the book, I talk about wondering, was this for a heart disease medication and is she going to land in the hospital now with a heart attack? Or is it for a cancer treatment that is going to impair her survival if she can't get it? Or is it just for a drug that if anybody thought more about it, they could have given her a generic and it would have, or a biosimilar would have cost much less and she could have had her medicine. But, the system is so deranged that patients and doctors and pharmacists all need to kind of lean in and try to make the system not be as abusive of them as they can.
So if you had the power to reform one major aspect of the drug approval and pricing system, what would it be?
Wow, great question, Jeff. I would say that FDA needs to go back to its roots and demand that every drug it approves doesn't just show that it makes a lab test better, but that the company is obliged to show that it actually makes the patient better. I suggest in the book that we could have such a thing as a conditional approval, where they say, okay, we're going to let this out there because maybe it'll help people. You've got a year to finish your studies and show that it actually benefits people and doesn't just change a lab test. That was what we had in mind as a nation back in the 60s when FDA was given the power. Really, it became a model for the world to say you can't sell a drug unless you show it helps patients. And we've really drifted away from that. I just want us to go back to that, at least on the effectiveness side, and say that FDA has got to return to its roots and not sort of take the shortcut of saying, well, the lab test is better, go market the drug, and we may or may not remember to ask you to do the follow-up studies. And if I may, Jeff, let me sneak in one other if I ruled the world answer, and that is if we could also do what most every other wealthy nation on earth does, but we have made it illegal in this country to really look at how cost-effective a drug is. There is literally language on the books making it illegal to do cost-effectiveness research on drugs to the extent that it might influence whether the drug is paid for by Medicare or Medicaid, which is crazy. You shouldn't make research illegal. And we got to use it carefully, but we want to have people in place, as they do in Germany, France, Canada, Australia, Japan, who are commissioned to look at these new drugs and say, yep, this is a great improvement. Let's pay a lot for it. No, this is not any better than what we got. We should pay only what the generic costs. We need that to happen as a function funded by the public in this country and not say, oh, what are they doing in Germany? We ought to be able to do that for ourselves. So that's on the cost piece. You would rapidly find that a lot of these drugs that are not worth their weight in gold and frankly are not worth much of anything would immediately not be able to get away with the prices that they are getting away with if we had that kind of analysis. So that's my other, if I ruled the world, thing I would put in place.
Well, we got to give you some more power.
All right, I'll take it.
So what are you doing personally to age well? It's a question we ask of all our guests.
All right. I think, as you no doubt know, Jeff, and as I think a lot of your guests have probably said, it really does come down to stuff that, one's grandmother probably would have told you. Namely, eat a reasonable diet, no fad foods, there's no magic bullets, not too many calories, not too much fat, not too much sugar, a lot of vegetables, a lot of grains, that kind of stuff. That is probably one of the more important things people can do for themselves. The other important thing I don't do, which is get enough exercise. I always could do more. I do way less than I should, but that's kind of an obvious, everyone should do that. And I think the third thing is sort of maintain relationships, because I don't know any great randomized trials, because you couldn't randomize this. People who seem to stay engaged in their communities and with friends and with family seem to do better into old age than people who live isolated lives. So, get out more is something I, again, could do more of. But that I think is the third pillar of, diet, exercise, and socialization are probably the best things we know. And as you implied earlier, there are these fad of the moment things, whether it's, red wine or, cauliflower or cider vinegar or whatever. I've not seen any of those really subjected to the kind of rigorous evidence that we would like to see for an intervention. So I'm sticking with the old grandmother common sense things for now.
Yeah, it is a lot of common sense. And I started off really with 4 pillars. I teach a pathophysiology and exercise class as part of my curriculum. And teaching that class, I realized, if you do these 4 things, if you have regular physical activity and exercise, maintain a healthy body composition, and I'm missing one in there. Exercise, maintain a healthy body, that comes with healthy diet, and then don't smoke. Those were my 4 to start.
Yeah.
And then we've since doing this podcast, I've added on top of that sleep hygiene and purposeful social connections. And because that just keeps coming back up. And I think those 6 things, if we do those, we're going to, these issues with all the cost of these drugs will minimize a little bit more. And then we'll be able to focus on getting the people that are the most sick, the healthiest.
I think you're absolutely right about that. And I guess one sort of overarching thought about meds is that, they are neither the devil's brew nor a godsend from heaven. And I think there's a lot of faddish prescribing that goes on, and there's also a lot of faddish deprescribing which goes on. And I think the right way to do it is, as with so many other things in life, is to just do it, in moderation based on the evidence. Drugs are neither our biggest salvation or our biggest curse. We just need to use them based on the evidence intelligently and carefully.
It's good. And have we missed anything in the conversation?
No, I think you had great questions. I think we covered everything. And I'm glad you got me to mention that appendix in the book, because that's what I think people can turn to, even if you skip the first many hundred pages and just say, okay, I got a visit with a doctor coming up on Thursday. I'm going to look at this and see what I should ask. And here's some websites I can use. And, even if you're not interested in the fascinating story of how come drugs are so expensive and why they sometimes don't work, there's that. But, drugs are a good thing. As I might have said when I was in college, I'm really into drugs. I believe in them. I think that they...
That's because you were in the 70s.
Right, exactly. Used well, they are like one of the best things we have. We just need to use them, intelligently and based on the evidence.
And so where can our listeners and viewers learn more about your work? And more importantly, where can they find the book? As this gets released, it's going to be, I think, about a day or two before the book actually gets physically released. And so
right,
where can they find it?
It is already up on Amazon as of this recording date. And so people could even pre-order it, although this will probably not air until closer to the pub date. But, they can have it, in bookstores and in their deliveries right around April 22nd. And you go to your favorite bookstore if they still have bookstores. In the book, I mention a lot of the kind of academic websites of my research division at Harvard, where we put all of our findings up for anyone to just look at, for free, because that's why we do it. And so there's a lot of websites about our studies of medications and our studies of drug policy that are listed among the kind of news you can use mentions in the appendix that describe all the studies. We've got dozens of pages of notes so that if somebody wants to look up the paper that I might have cited, or a media article describing an FDA hearing, or a website that is a useful one for patients, they're all listed there, and you can just type right in and go right to that site as well.
Okay, well, the book is a great read. I still have a little bit more to read on it, but I'm finding it kind of a good view of the history, the policy needs, as well as, where we are politically. And I think it's something that can inform the consumer, and then maybe we as consumers can push back and help facilitate some of the many changes that you talk about in the book and as we've talked about in the podcast here. So I thank you for writing that book, and I encourage all of our listeners and viewers to go out and get it. I know I'm giving them quite a library of books to buy through this podcast, but the more informed we are, I think the better we're going to age well.
Well, this will be the most entertaining to read, I think, because I tried to keep it light, even though the material is heavy. And I think a number of people who read it in the editing process said, yeah, I laughed out loud several times. So, and a lot of it is sort of my own experience in it. So I think people will find it entertaining as well as useful.
I hope they do. And I just, again, thank you, and just keep doing what you're doing and keep aging well.
Thank you very much. I appreciate talking to you, Jeff.
Thank you for listening. I hope you benefited from today's podcast. And until next time, keep aging well.